Hi guys, I'm going to talk about suicide in this chapter, and I want you to just be mindful of how you're feeling as you listen to this lecture. If your life has been impacted by someone that has taken their life by suicide, this may be very triggering for you to listen to this. So just be self-aware. If you need to take a break, take a break. But take care of yourself as you listen. So let's get started here. Clients who are profoundly depressed may express an interest in stopping the emotional turmoil that they are feeling through self-harm. Suicide is devastating. Suicide is defined as death caused by self-directed injuries, injurious behavior, with intent to die as a result of the behavior. Human life ends every 11 minutes as a result of suicide. Clients that are suicidal can be ambivalent about death, and intervening can make a big difference. A suicide attempt is a non-fatal, self-directed, potentially injurious behavior with the intent to die as a result of the behavior. A suicide attempt might not result in injury. So suicide attempt is engaging in that potentially self-injurious behavior with the intention, but it may not result in death, injuries, or no injuries. Suicidal ideation refers to thinking about, considering, or planning suicide. This could also include the wish to be dead, considering methods of accomplishing death, and formulating a plan. Those who cause death through a suicide attempt should not be referred to as a successful suicide, as it has the tragic outcome of death. It's important to classify suicide as a behavior, not as a disorder. So this was put out by NAMI, the National Alliance for Mental Illness, just stating it's okay to talk about suicide. I think people fear that if you talk about suicide, then you're planting the thought. If somebody is contemplating suicide, that thought has already crossed their mind. So talking about suicide isn't going to plant the thought, and it actually might save somebody's life. So it's okay to talk about suicide. The SAD Persons Scale is an attempt to assist non-psychiatrists in assessing suicide risk. It can help guide regarding the need for a referral or for admission. So you can see, I'll flip the slides here in just a second, but you can see it's going to be a simple to use scale. You score a point for each factor, and then you add those factors up. 0 to 2, going home with appropriate follow-up. 3 to 6, admission or discharge with appropriate follow-up. 7 to 10, they need to be admitted to the hospital. So you can see the SAD person's risk factors here, and it is just a mnemonic. So are they male? Age is less than 19 or greater than 45. D is for depression. Have they had history of depression? Are they going through a depressive time right now? P is a previous attempt. Have they attempted suicide in the past? E, ethanol. Are they drinking? R, do they have rational thinking loss? Social support, no social support? Do they have an organized plan? Is there a partner involved or no partner? And do they have any major chronic illnesses? Major illnesses or chronic illnesses. And so you would add each of those risks up, and then depending on how many risk factors they had would really determine on admission versus no admission. So while it might seem uncomfortable for nurses to ask these questions, it's important to determine if patients are at risk of suicide. So asking these questions again will not cause the client to consider suicide. It's the role of the nurse to protect them to protect their safety. So I would really encourage you to find somebody that you can just ask these questions to. See what their risks are, and just so you're familiar with how to ask the questions. So these next few slides are just going to assess, again, more risk factors. What are the individual risk factors? Again, some of these will fall on that scale. Have they made a previous attempt? Do they have history of mental illness? What does their support system look like? Do they have somebody they can call and say, hey, I'm struggling? Do they have any legal or financial problems? Are they risky? Do they have risky behaviors or impulsive behaviors? You're going to find that kind of in that younger 20s, older adolescents. Have they just recently lost a job, any serious medical illnesses, or any use of substances? And any of those risk factors on an individual basis could just put them at higher risk for suicide. What about relationship risk factors? Are they being abused? Have they been abused? Were they neglected as a child? Any bullying that's been going on? Do they have a family history of suicide, personal relationship problems, or any sexual violence? Community or society, do they have barriers to access to get some health care? Are there any cultural or religious beliefs? Community cluster of suicide, unfortunately, that becomes an issue. It's almost that copycat suicide where, maybe this 19-year-old girl commits suicide and her friend is so distraught that she commits suicide, and then that friend commits suicide, or they hear about it and they're going through a depressed time, and so there's clusters of them that could happen. So being aware of what's going on in the community. Do they have access to lethal weapons or medication for overdoses? And how is the media portraying suicide? Are they glorifying it where it's something you can do to get rid of the pain or this discomfort or the anxiety or whatever's going on? So sometimes media can unfortunately play a role. Some of the cultural factors that we can think about, again, are religious beliefs, family values, sexual orientation, gender identity. Are they identifying as the gender that they were born with? Are they identifying as something different? A lot of times those LGBTQ plus, they're gonna just have more bullying problems. They're gonna have more identity problems, right? It's just going to increase those risks. So making sure that we're just mindful of that. So then our should plan to address client suicidal ideation by the least restrictive measures first, and then make sure we're speaking with the client and developing a plan for their safety. So some of the immediate warning signs, if they say they want to die or kill themselves, that becomes a safety issue, right? We need to listen to those suicidal ideations and then develop a plan for safety. Are they stating that they feel hopeless or empty? Do they feel trapped without a solution or a problem? Do they feel physically or emotional pain that is just unbearable for them? Are they stating that they're a burden to others? Have they withdrawn socially from family and friends? Are they giving away their possessions, telling everybody goodbye, arranging their affairs? Those would all be very immediate warning signs that we need to recognize and see, and then develop a safety plan for. Other warning signs that we consider or we need to look at are sudden and extreme mood swings. Are they like going from crying to laughing to angry, right? Do they have really big mood swings? Have they developed a plan? Are they collecting pills, buying guns? Are they complaining about feeling guilty or shameful? Are they now increasing their use of drugs or alcohol? Are they changing their eating or sleeping habits? Although environmental features that prevent suicide are usually part of the construction of inpatient psych units, there are many ways that clients can still harm themselves on non-psychiatric units. So for this reason, we have to assess suicide with every single client in every healthcare facility on every unit. So this again is just a recap. It's looking at what are they saying, what is their mood, and what is their behavior. So when we talk to them, are they a burden? Are they experiencing unbearable pain? Are they talking about killing themselves? Do they have no reason to live? Do they feel trapped? Is their mood depressed, loss of interest, irritable, rage, anxious? And then what are some of the behaviors that we can note? Increased alcohol, acting reckless, withdrawing from activities, isolating themselves, sleeping too much or sleeping too little. Again, these are real red flag warning signs that we need to be aware of. So let's apply the nursing process. And again, we know that this starts with assessment, and it's essential to establish that therapeutic relationship. So we're looking for verbal and nonverbal clues. So we have to ask the patient, are you considering suicide? And then listening to the comments back from the clients. Comments or signals from the clients that are contemplating suicide can be overt or direct messages, or covert or indirect messages. So those overt are those open messages. So they may say, I can't take it anymore. I wish I were dead, right? That's a very direct message. So that's that overt message. Or a covert might be more concealed. So they may say things like, it's okay now. Soon everything will be fine. Things never work out. It won't be a problem much longer. So those are very concealed messages. Like, what do you mean it won't be a problem much longer? What do you mean everything will be fine soon? So asking them about suicide and then listening for those statements. People contemplating suicide are relieved to talk to someone about their despair and loneliness most of the time. Again, asking about suicide does not give that person the idea. Some nonverbal cues that we can look at are showing a sudden brightening in mood, right? All of a sudden they were depressed and now they're super happy, they're joyful. That might be a problem. They may be at really great risk if their mood lifts because they have the energy now to act on that plan. Giving away their possessions, writing letters, organizing finances. Those are all those nonverbal clues that we need to look at. And then we also need to look at the lethality of the suicide plan. So there are three main elements to consider with lethality. Is there a specific plan with details? How lethal is the proposed method? And is there access to the planned method? So based on the lethality of the method, you can classify it as high or low. It could also be referred to as hard or soft. So some of those hard methods include using a gun, jumping off of a high place like a bridge, hanging. Those are all very hard methods. Some of the softer methods or low methods would be cutting one's wrist, inhaling natural gases, maybe ingesting a bunch of pills. If the patient confirms access to the proposed method, then the situation becomes more serious. Making sure we're always doing a self-assessment. Health professionals, if you are working with someone that is contemplating suicide or they just attempted suicide, there may be a lot of fear. There may be a lot of grief, maybe some anger, puzzlement, like why? Or even condemnation. So we have to, as nurses, determine how we feel about suicide. We have to be able to ask the uncomfortable questions about suicide and those suicidal ideations. So analysis, outcomes, and planning, that's just as we're moving down our nursing process. We've done our assessment. Now we need to analyze the data that we've collected. So the plan of care for the patient with suicidal ideation is really based on risk and protective factors. When there's a comorbid psychiatric disorder, the treatment plan usually includes just those appropriate nursing approaches. And then we may need to do some interventions, and then definitely evaluating our outcomes. So psychosocial interventions, this is key to establishing that therapeutic alliance, encouraging the patient to engage in more realistic problem solving. Health teachings and health promotions, we're teaching about community resources, coping skills, stress management, communication skills, and then developing a safety plan is also important in that piece. We can talk with case management, that milieu therapy remembers that safe healing space, documenting all of the care that we've done, and then suicide survivors. We have to remember, if your loved one has just successfully died because of suicide, they leave a lot of people behind. Those survivors are still behind, and those survivors need help too. So postvention with the survivors. It's estimated that for every suicide, there are 60 survivors. So nurses have to be prepared to encounter family and friends that are just experiencing an overwhelming guilt and shame. And a lot of times you'll hear like, why didn't I see it? What could I have done, right? It's that guilt and shame. And then evaluation is ongoing. So we're constantly alert to those mood changes, what the patient's thinking, what does their behaviors look like. And nurses are always looking for those indications that the patient is communicating thoughts and feelings more readily, and that the patient's social network is widening. Suicidal behavior is the result of that interpersonal turmoil. So these are some environmental safety guidelines just to minimize suicidal behaviors on especially a psychiatric unit. I know at Children's Mercy on our floor, we have a one room dedicated to someone that is suicidal. And so it really has taken into account all of these guidelines. Like, right, we don't give them metal utensils. They get plastic utensils, and we count that when it goes in the room. Keep the door open at all times. It's jump proof, hang proof. They can lock the doors to any non-patient areas, monitoring for any harmful gifts that might come in, and just making sure that they're not bringing things in, like families not bringing in things that might be very harmful for that patient. Some of the treatment modalities that we can talk about are biological treatments and then psychological therapies. The Psychiatric Mental Health Advanced Practice Registered Nurse can treat patients with suicidal ideation directly with psychotherapy, psychobiological interventions, clinical supervision, consultations, really in any non-psychiatric setting. So remember, just because they're on a med-surg unit doesn't mean that they may not have those thoughts ruminating. So just again, being mindful of what's going on with your patient. And that concludes the chapter. Short and sweet, just to the point. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.